right, we'll go ahead and get started. Good evening. I'm Katie Henderson, Vice President and Chief Medical Officer at Barnes-Jewish Hospital. I wanted to start the evening by personally welcoming all of you, both those who are in person here with us and those joining virtually, for our second Leading Edge Medicine program of 2023. Our Leading Edge Medicine series is an exclusive opportunity to hear firsthand about the incredible innovations and discoveries happening right here in St. Louis thanks to donors like you. Tonight, you'll gain valuable insight into the future of cardiac health care from our very own Dr. Sumanth Prabhu. Dr. Prabhu is the Tobias and Hortense Lewin Distinguished Professor of Cardiovascular Diseases, as well as the Division Chief for Cardiology at Washington University. Excuse me. He is a heart failure cardiologist, a physician scientist, and a mentor to those in his field. His research, which has been funded by the NIH and the VA for more than 20 years, has focused on the role of inflammation and the immune system in heart failure. We are grateful to our visionary donors who make cutting-edge research like this, like you will hear about tonight, possible, and who advance our mission to enrich lives, improve the health of our community, and transform healthcare. Susan L., Vice President of the Foundation, will share a little bit more about Dr. Prabhu in just a moment. But first, I'd like to recognize the Foundation board members who are here tonight. They're wearing silver name tags so that you can identify them. I want to thank you all for your service. We really appreciate everything that you do. All right. And our foundation team members are also here with us tonight. They're also wearing silver name tags, so please make sure and stop by and say hello to them as well. All right, Susan, I'm going to turn it over to you so that you can give a little bit more information about our featured speaker.
Well, thank you, Dr. Henderson. There's so much to say about Dr. Prabhu. I have to have the remarks in front of me. I don't want to miss anything. So his research is focused on understanding how the immune system can drive changes in the heart that play an important role in acute and chronic heart failure. Dr. Prabhu's work has shed light on how altered function of immune cells, such as macrophages, if I'm saying that correctly, and T cells, can drive heart failure. Dr. Prabhu earned his medical degree from Jefferson Medical College in Philadelphia and completed his residency in internal medicine at the University of Pittsburgh. He continued his training with a cardiology fellowship at the University of Texas Health Science Center in San Antonio, where he later joined the faculty. Before joining our team, Dr. Prabhu was the director of the Division of Cardiovascular Disease and the Mary G. Waters Chair of Cardiovascular Medicine at the University of Alabama in Birmingham. Prior to that, he served on the faculty at the University of Louisville. All of this to say, Dr. Prabhu's vast experience and experiences have given him special insight to be able to talk about immunity and the contributing factors that inflammation has on heart failure. Aside from his extensive schooling, Dr. Prabhu is also board certified in internal medicine, cardiovascular disease, and advanced heart failure and transplant cardiology. He has received several honors and awards, including being named an established investigator of the American Heart Association. He has served as a National Institutes of Health reviewer for a number of special emphasis panels and scientific review groups. Also on the study sections of cardiac contractility, hypertrophy and failure, and mentored patient-oriented research. Ultimately, Dr. Prabhu is elevating the conversation around heart disease and immunities to improve the experience of all the patients his team sees. Tonight, Dr. Prabhu is going to discuss heart failure as a leading cause of disability in the United States, contributing to more than 35% of all deaths from cardiovascular disease. Nearly 1 million new cases are diagnosed annually. In the last few years, his team has uncovered important links between immune system activation and the progression of heart failure. This evolution is just the beginning and will serve as the template for transformation of many more healthcare services. It is an exciting, forward-thinking concept, and like you, I am looking forward to hearing more about it tonight from Dr. Prabhu. After Dr. Prabhu's presentation, You'll have an opportunity to ask questions and learn more, both those of you who are in the room and those of you who are joining us virtually. And then we will wrap up our evening. You will once again hear from Dr. Katie Henderson. And so having said all of that, I know you're excited to hear what Dr. Prabhu has to say. I am, and I think this is the best show in town, regardless of the fact that there's a Cardinals game going on right now. So now, please, join me in welcoming Dr. Sumanth Prabhu. Doctor.
Thanks so much. So it's a real pleasure to be here. I want to thank the foundation for inviting me to come and talk to you about two of the subjects that are really near and dear to my heart, no pun intended. As you heard, I'm a heart failure cardiologist, so I spend my clinical time really looking at patients, taking care of patients with heart failure, all the different presentations. And for the last maybe 25, 30 years, I've really been fascinated with what are the drivers of heart failure. Why does the heart fail? What can we do to improve this disease and improve the quality of life and outcomes for our patients? And so this talk really is going to be divided into two sections. First, we'll focus on heart failure, and then we'll kind of shift into another discipline. It's a poor man's immunology, and whenever you're trying to do work that links two different disciplines together, this is a leap of faith of sorts. And I think that over the last 10 years now, there's been an explosion of work now focused on a field called cardioimmunology. And this is really driving an understanding of the failing heart to a level that we previously did not appreciate. And I think in the next 10 years, this might cross over into clinical practice. And we'll talk a little bit more about that. So this is an image that I just wanted to show because, well, it's a cool image. It's a simulation. I didn't even look for it. It came to me on LinkedIn. It's amazing what people are posting these days. So I opened up my LinkedIn page and I see this heart. And I think it's the best simulation of a contractile heart. This is a pure simulation of how the heart moves. So really all I wanted to show here was that this is a orchestra of closely harmonized events, okay? And the heart contracts and it also relaxes. And so these are, from a pump standpoint, two of the main mechanisms of how the heart is able to fill and eject blood. So heart failure, the first question then is what is heart failure? And I know that we have a lot of non-medical people, and so I really want to keep this more informal and hopefully not too technical. If I get too technical, just stop me. But what is heart failure? So really, if you look at the heart as both a pump and an organ that relaxes, impairment of either of those functions, pumping or filling, can lead to a syndrome that we consider heart failure, which is this. And this is what a patient experiences. Doc, I'm short of breath. I get winded easy. I'm always tired. I can't do what I used to do. I'm swelling. I'm swelling with fluid. And these are very common symptoms when you have heart failure. And by the way, the heart failure is a common disease, and I wonder there are probably many in this room who either themselves or a family member have been touched by this disease. And so for all of those folks and all the folks that you know, I think this is a very, very important and scenario that people who get ill with heart failure have to deal with. So these are the symptoms, but they're really the end effect, a common end pathway for multiple underlying heart diseases. So this includes coronary artery disease, myocardial infarction or heart attacks. This includes heart valve disease, so aortic stenosis you might have heard of, hypertension or high blood pressure, cardiomyopathy from genetic mutations, which is more and more common than we previously recognized. All of these things can result over time in this heart failure syndrome. So this is the problem, all right? So if we were to look at the problem purely from the standpoint of how common this disease is, there are about 6 to 7 million people with heart failure in the US. And if you do the math, that's about 2 to 3% of the adult population. So out of every 100 people, 2 to 3 people will have heart failure. And this prevalence, this is increasing by 1 million new cases each year. And if you look at it, it really is more prominent as we age. So these are age groups from 40 to 59, 60 to 79, and so forth. And you can see that as you get older, between 7 and 10% of the population will have symptoms or signs of heart failure. So this is a big problem, and it's estimated, the American Heart Association puts out annual statistics, and it's projected by the AHA that this will increase by 46% in the year 2030 from 2012. So as we're getting better at treating heart attacks, as we're getting better at treating arrhythmias, as we're getting better at treating aortic stenosis, unfortunately, as we age, we will see more heart failure. So this is a problem that is not only medical, but societal, and we have a projected total economic cost of $70 billion in 2030. So this is a big issue, both from a medical standpoint, from a personal standpoint, as well as a societal standpoint. And once you reach age 50, and I'm over age 50, the lifetime risk of having heart failure is 25%. So these are very sobering numbers. And what we really want to do is, how can we stem this tide? So, cardiologists, we work a lot with images, and that's one of the reasons that I got interested in cardiology, is because we can see things as to how the heart contracts. We can quantitate things. We can be very, very precise in terms of the function of the heart. And so you don't have to be a heart doctor to see this image. These are cardiac MRIs. This patient is normal. And I think everybody can see, just like in that simulation, the simulation showed the heart contracting and relaxing, and you can kind of see the blood moving back and forth in this heart, right? So this is a normal heart. And then if you have any familiarity with heart disease, et cetera, we use a lot of numbers to quantitate the heart function. And one of the numbers we use is called the ejection fraction, or how much blood is pumped out from the heart every beat. So this person has a normal ejection fraction. Now look at this patient here on the right. I think it's pretty obvious that the heart is not contracting very well. And this person has a markedly reduced ejection fraction of 15%. And if you have a good eye and look really closely, you'll see that this part of the heart is not moving at all. And that's because that patient has had a heart attack in that region years ago. And now, over time, this heart is starting to fail. So we have a term, it's called cardiac remodeling. It's like you remodel your house and things like that. The heart remodels when it goes from a normal heart to a failing heart. So this heart, before that heart attack, looked like this. But over time, everything in that heart has changed. And so the current treatments for heart failure is really trying to stem this process, all right? And in this process, there are a lot of things that happen in the body. Your adrenaline goes up, your several neurohormones go up, and many of the drugs that we have, and I've kind of put it in graphic form here, we have multiple classes of drugs. There are 4 main pillars, but all these drugs are really trying to stem this process of what takes the heart from this to this. How can we impact cardiac remodeling so that we improve outcomes in patients? So for people that are on these medicines, some respond extremely well, and some less well and do progress. And for those patients who have advanced heart failure, which is about 10% of people, we have options that are unrelated to drugs. And these are either mechanical pumps or heart transplantation. Now, if you think of the numbers that I told you, If you look at 10% of heart failure patients, that's about 700,000 patients with advanced heart failure who have failed or failed to respond adequately to these medications. And if you look at this number, we only do, last year we have data available, 3,800 heart transplants. So there is a huge gap between a therapy that is a heart replacement or a transplant and the number of patients that might need that heart transplant. So, and the other thing is that heart transplant is really not a cure. And when I was training, one of my mentors told me that a heart transplant is not a cure. It's basically trading one disease for another. And the heart transplanted heart also has its own issues over time. So we really would like to avoid this if possible and improve this if possible to prevent this. And that's what we really aim to do, okay? Now, this is the issue. We have all these treatments for heart failure, but if you look over the last 10 years, last decade, what this is a graph of overall mortality, one-year mortality in patients with new heart failure, so the first time they present with this disease. And if you look at here in 2002 versus 2013, there's really been very little change in overall mortality. Now, the heart mortality in blue here, the cardiovascular mortality, we have made an impact. It's gone from about 18% to 15%, so that is a good thing. But really, patients really don't care if it's heart or unrelated. There's multiple things going on, and we really need to improve on these numbers, okay? So how might we improve on these numbers? Well, we need to look at the patient in a way that where can we intervene, okay? And so this, unfortunately, this doesn't project as well as I thought, but what I've done here is showing you a graph of how we classify patients with heart failure. We go by a functional classification from the New York Heart Association, or NYHA. And this is very commonly used by physicians, by providers. And once you get, as you go from 1 to 4, the disease becomes more advanced. In NYHA class 3, you see this red line here, that's patient survival. And this dotted line here is the number of hospitalizations that patients have to endure as they go through this disease. And here's the place we want to intervene with better therapies to stem this increase in hospitalizations. Because every time there's a hospitalization, the patient, for lack of a better word, the disease takes a toll on the patient every time they get hospitalized. So what you see here is the functional class decreases, you bounce back up, you decrease, bounce back up, and so forth, and over time, this becomes very progressive. Now, heart failure is not a disease like cancer, so the survival curves and the functional decline in cancer is more of a straight line, all right? There's peaks and valleys here, so patients feel better. But when they feel better is really the time we should really be aggressive in trying to get them optimized on their therapies, okay? You know, it's hard to start medications when patients are feeling well, but knowing the natural history, we really need to intervene at earlier stages. So we want to try to avoid getting in this NYHA 3 category. And this is what we hope to do. So with our current therapies, we are seeing a decline like we talked about with these peaks and valleys every time there are events or hospitalizations. So what we hope to do with new treatments is to change the slope of this survival curve. Not only that, but once there is an event, you come back to the same, a better level than you would on this curve, okay? And then this green part here, the other part is that we want to look at, very importantly, is there a potential for this heart to recover rather than progress? So here we've talked about our current therapies leading to a reduced progression of disease. If we can intervene early enough with more specific therapies, can we actually recover the disease? And this is a paradigm shift in thinking and in perspective. Can we recover the heart? And this is something that I'll talk about in a bit. So let's switch gears now. So I hope that I've convinced you that heart failure is a bad disease. and how we look at treating this disease for patients and how we can intervene on the course of disease in those patients. But in all of the treatments that we have, we don't have anything that targets this, which, Time magazine, this is about 20 years ago, put inflammation as the secret killer. And it turns out that most chronic diseases are marked by chronic inflammation. And heart failure is marked by chronic inflammation. And yet, over all this time, we have not had any therapy that successfully targets heart failure successfully targets inflammation to try to improve outcomes in heart failure. And this is a big knowledge gap for us and a big treatment opportunity if we could overcome that knowledge gap for patients, okay? And so we have to think about what is inflammation. I think everybody's heard about inflammation, anti-inflammatory diet. How can we get rid of inflammation, et cetera, et cetera. But what is it? So, this is what inflammation is. It's really a self-protective response. We often can think about it if you get a cut in your skin and it gets infected. That cut becomes red, it becomes painful, it becomes warm, it becomes swollen. And that is a classic inflammatory response. And the reason this happens is when you have an injury, immune cells that make up the inflammatory response just come and recruit it to that site and cause all these responses to affect healing. Well, it turns out that you don't need an infection to have this. You can have sterile damage, and sterile damage can cause inflammation. And that inflammation is what occurs in chronic heart disease, okay? And so this is mediated by immune cells. So if we then take another look at that patient with the heart that we see, we will look at, on the standpoint of how these immune cells, which make up the inflammatory response, impact the heart. So let me just step back. This is college biology or medical school. I don't want to get too technical, but all of these cells make up the immune system. And it's not a patchwork, but it's really a team. So you have teams of these cells. You have the first responders. The first responders sense injury and lead to the initial inflammatory response. You have the cells, the long-termers, the B cells and the T cells. They make antibodies. They will often have what we call immune memory, so that if you get hurt again, they'll activate. And then you have these cells, macrophages, dendritic cells, that form a link between this first response and this long-term response. And when you have inflammation, any or all of these, in different degrees, any or all of these cells can be activated and expand. So how might that work in heart failure? So if we go back to that patient where we saw a big dilated heart, we saw a prior heart attack, and we saw a lack of function, and we look at it from a different perspective. What is the inflammatory response? It is a failing heart is an inflamed heart. So a lot of those same processes that would occur if you cut yourself and got an infection is occurring in the heart and doesn't go away because it stays with you. And if we look inside that heart, what we see is we have the heart muscle cells, and that's just shown graphically here. But in between those heart muscle cells, there are many other cell types in the heart. And in heart failure, these immune cells that are shown here, the macrophages, neutrophils, T cells, B cells, they are all expanded in this heart. And not only are they expanded, but they're active. And just like they are producing damage after an infection, they're also producing damage within the heart. So here we have a way, thank you. So here we have a way perhaps to target how the heart might remodel related to inflammation. So let me show you how we can look at this. So one of the issues with advancing knowledge in terms of biology of the heart is, unlike, for example, the field of cancer where you take a tumor out, it's very, very hard to get heart tissue. Well, that all changed about 2 decades ago when we had a device. This was a technical innovation. This is called the left ventricular assist device. I hope, and many of you may have heard of it. So this is a LVAD for short. And this is a treatment for people with advanced heart failure who have failed therapies. So when you have such a patient, a mechanical pump can be placed in the heart as a bridge to heart transplantation, so they can be maintained on this device for some time until you have a heart transplant. Or in some patients who are not candidates for transplant, we use it for what we call destination therapy, and that is their last treatment for heart failure, so they maintain themselves on this device. But when this device is placed, this intake cannula has to be placed inside the heart so that blood can go through the pump and back into the aorta. And so this is a pump that is supporting the heart. It's taken over for some of the heart function. So when we do that, we can take out the heart tissue, and then we can analyze that heart tissue. So we have a way then to look at events in the heart tissue in patients with heart failure. And so this is an example of what we can do. So here, all this green here is a stain that we can see under a microscope for macrophages. One of the immune cells that we see in animal studies is expanded in the heart. And so this is a non-failing control. This is a patient that donated organs for transplant, but the heart was not technically usable. And when I was in Birmingham, we got this from the Alabama Organ Center. These patients had donated those hearts as part of the transplant protocol and donation. And very hard to come by these hearts, but we're indebted to the donors that have donated this because it's allowed us to make observations comparing controls without heart failure to patients with heart failure. And what you see is these are 2 patients, and this is that apical core that comes out from the LVAD. And you see a lot more green here than you do here. So what this means is there are a lot more macrophages inside the heart, and these macrophages are inducing damage. And very interestingly, this is the same patient's heart when that patient received the transplant. So we can look at the transplanted, we can look at the supported heart at the time the patient receives a transplant and see what the effect is of that mechanical pump. And what you see here is if you reduce the load on that heart with that mechanical pump, you reduce the inflammation. You reduce the amount of cells that are coming in. So the progression of heart failure and the regression of heart failure, at least with load, is linked to a progression and regression of inflammation. And so what does this all mean then? So in our research laboratory, in our basic research laboratory, we usually employ this, overall study design. And really we're trying to answer these 3 questions. Are there specific immune cell types in the heart that are primed to induce cardiac injury? Because the immune system, like everything else, you have to use a scalpel, not a cudgel. You have to be very precise as to what you target. The second thing is which of these cells are necessary for disease progression? And then, most importantly, can we target specific cells therapeutically to induce an improvement in outcomes? So I don't want to go through the studies, but I would like to just say that of all of these different immune cell types, monocytes, macrophages, neutrophils, dendritic cells, T cells, these are all expanded or activated in heart failure. So there is a generalized inflammatory response. Okay? And as we'll see, that these cells, monocytes, macrophages, and T cells have been shown to be potential targets for therapy based on these animal studies. So let me just show you one example, and I didn't want to make this too technical, but this was probably one of the best study outcomes that we had that we got very excited about many years ago. It was on the cover of Circulation Research, and let me just walk you through what we did. Here, this is in mice, and we can induce a heart attack in mice, and they'll develop heart failure. So if we take a mouse with heart failure or a controlled sham-operated mouse, and we take out their spleen, which is really rich in immune cells, And we just take those splenic immune cells and just transplant them, transfer them into a normal mouse, and wait 8 weeks. What we see is that the heart becomes dysfunctional. Let's see if I could. Yeah, so these are echocardiograms, and if you can see, it's a little more subtle, but this heart doesn't contract as well as that heart. And this is because we've transferred the splenocytes from a mouse with heart failure. These mice were totally normal before we did this transplant. So what we've done is we've transferred disease from one animal to a normal animal by transferring their immune cells. And so what does this mean? It means the immune cells remember that immune cells are primed with immune memory to cause heart damage. And this is what we think is happening in patients. Okay? So how can we use this information to understand what is happening in patients, what is happening that causes a disease to progress, and how we can then perhaps leverage this into therapy for our patients with heart failure. So remember I told you that we had stages of disease. So when that heart remodels, there's a latent period. It's called stage B, or pre-heart failure. The AHA and the American College of Cardiology classified the disease stages of heart failure: stage A, stage B, stage C, and stage D. So stage A is when you have risk factors. So here it's very important to treat high blood pressure, for example. It's very important to treat cholesterol elevations if you are in that category that is requiring treatment. But stage B, the heart has some abnormalities. We might see that on an echocardiogram. We might see that on an MRI, incidentally. But these patients have no symptoms. So the time it takes a patient to go from no symptoms to symptoms is highly variable in many patients. And this really is where an early intervention might help. And when a patient first presents with symptoms, that might be an indication, a window as to how these factors that cause transitions between these two stages can be identified. All right? So this is an example of a patient I took care of at Birmingham, who had his first presentation of heart failure. So this is a new onset heart failure. And what I'm showing you here is a PET scan. Does everybody know what a PET scan is? A PET scan is an imaging procedure which uses a tracer. Here, this is a tracer for glucose. It's fluorodeoxyglucose. And what this does is this is taken up by cells that are metabolically active. So PET scans are used to follow patients with cancer, for example, because the cancer cells are metabolically active and they can be detected on these PET studies. So instead of using a PET scan to detect cancer, we wanted to use the PET scan to detect activity of immune cells. And so if we look at this patient with heart failure, and we look at the bone marrow, this is the spine, and within these vertebrae there are bone marrow cells. These numbers indicate there is high activity of this metabolic tracer in this PET scan. And if we look at the spleen, remember we transferred the spleen in those mice, normal mice, we had heart failure. We have high activity of the spleen. So this means that there are certain patients that have a robust, almost runaway immune and inflammatory response. And this may be one indicator of who might respond to therapy that targets that response. And so the idea here would be that if we have a patient early in disease, remember that natural history curve. We really want to intervene early in disease to change that curve, right? If we look at that patient, and then we use newer ways to look at what's happening in the entire body, PET scanning, MRI imaging, flow cytometry is looking at certain immune cells, biomarkers and their clinical characteristics. What we would like to do is to determine what we call disease endotypes. And these are subsets of disease that have specific patterns or profiles of immune activation. And in that way, we can then select out patients that have a possibility or a higher probability of responding to a modulation of inflammation and immunomodulation therapy. Okay? So the second really more provocative question is, if we use this we can use this to classify and identify patients that might respond to therapy. But is there a way to reverse the remodeling? Can we reverse heart failure by using a approach that targets immune cells? So this is another patient of mine. This was actually when I was in Louisville. And you remember all these patients because every patient has a story. And the stories you remember are the patients that really improve, and we don't know why they improve, because it really surprises us, right? It's really the patients are trying to tell us there's something that we're missing that we can use to benefit a whole group of patients with this disease. So this was a patient who was referred for heart transplant. So imagine that. He was very sick. He was not functional the way he wanted to be. He couldn't walk very far without getting breathless. But he wasn't really well treated with medicines. So essentially, we treated him with medicines. And over 5 years, if you look at this, these are echocardiograms. And we're measuring the heart volume, and we're measuring that ejection fraction. So after 5 years of therapy, this patient had what we call myocardial recovery, which means that his heart shrunk and his heart function improved to the normal range. So low normal range is 50 to 55%. So every so often, and we're recognizing this more and more now as our therapeutics advance, there is a subset of patients we call recovered heart failure. So we have a name for that. We have little acronyms for everything. But so heart failure recovered EF is what we call this. But this raises the question of, is heart failure really an irreversible disease? And what I think is sometimes it is, but oftentimes it is not. And so this raises the concept of what I would call heart plasticity. Is the heart plastic? You have progressive disease. We saw that natural history curve. But can we go back along that curve to an earlier time point? And here we really need to understand the biology of the heart in a way that we have not done before. And we think that one of the keys to try to do this is to manipulate or modulate the immune response in these hearts. All right, so what we would think is that there's a disease progression continuum. We have forward remodeling, going from that normal heart to that dilated heart. We can have reverse remodeling, what this patient did, going from a dilated heart to a not dilated heart. And we can have, at the extreme end of this, cardiac recovery. So we're just starting to understand how can we move patients along that continuum, whether we can move patients along that continuum, does that apply to all patients? And this is a very exciting time in trying to find this, because technological advances now has made it much more possible to look at events in the heart with imaging or with the analysis of tissue. So what we would then think is that if we target these immune cells, we can then go from a paradigm that says we go from acute inflammation to chronic inflammation, we go from tissue repair to tissue destruction, we go from a reversible heart dysfunction to an irreversible heart dysfunction. But here's what we found in animal studies. If we target monocytes, if we target macrophages and specific populations of regulatory T cells, we can reverse remodeling in these mice. So that begs the question, can we do the same thing in patients? And we're not there yet, but this is what could be done perhaps. This is with the approaches that we use. We can use monoclonal antibodies, for example, against some of these cells. We can use anti-cytokine or chemokine approaches. We could broadly immunomodulate, and we could target specific pathways or autoimmunity or antigens. And here's the thing. So it's really wonderful this is the foundation for Barnes-Jewish Hospital, because these are the kinds of projects that really need support to move from the animal model to the patient, because getting there is a very long road. We have to identify the targets. We have to validate the targets. We have to develop newer ways of imaging, and we have to look at newer ways of therapy. We have to do large animal testing, and finally we have to do human trials. As you can imagine, all of that takes a lot of support. And it's not always support that is readily evident to funding bodies that need a lot of data and preclinical data in order to take this kind of work into a rapid progression. And here's where it's very important for foundations such as the BJH Foundation and other organizations that, again, sometimes take a leap of faith for a high-risk, high-reward kind of project to see if we can bring this to a reality. And I would like to say that I personally think that this is the next frontier of treatment in heart failure. And I looked at the oncology world. Now, my wife's an oncologist, so they're actually 10 years, 15 years ahead of us in terms of manipulating the immune system to cause incredible cancer responses, right? So the last 15 years, we have seen just tremendous responses with immunotherapy, almost making cancer a chronic disease and not a deadly disease. And Jimmy Carter's a good example, treated with antibody therapy for melanoma, which was a universally deadly death sentence. He has done very well over the years with immunotherapy. Now, this is the immunotherapy, global cancer immunotherapy market. So for the former dean of the business school, this is the money aspect. So this is from a market US report that the market for global cancer immunotherapy is going to grow from its already high levels now about fourfold, 3 to 4-fold over the next 10 years. And some of these things, monoclonal antibodies, cytokines, immunomodulators, those are the exact kind of approaches that in animal models can help heart failure. So the thought is, can we then do a parallel kind of approach in heart failure? And this is what I view as the clinical side. I think the new frontier in heart failure is clinical cardioimmunology, where we use the knowledge that we're rapidly gaining from our animal studies, from our patient studies with evaluation of failing heart tissue, to look at a model like this. We identify particular subgroups of patients. We treat them with standard therapy. But in select groups, we use immunomodulation and targeted immunotherapy to change this from an irreversible to a reversible disease. And that would be the dream. That would be the holy grail. But we're not there yet. We still have a lot of work to do. But it would be a lot of exciting work to get there from where we are now. So I think that's it. And I would, I've shown a lot of work. I didn't really get into it, but there have been a lot of people that have helped along the way, and my laboratory, clinical collaborators at multiple institutions. And I'm happy to take questions, and I'll stop there. Thank you. Yes?
So thank you for a great presentation. And when we think in terms of the inflammation or immunological response, means you talked a lot about the medical intervention. But when it comes to inflammation, are there studies that provides that whether lifestyle changes or other elements that people might be able to control to work with the physician, but also reduce these immunological responses?
Yeah, no, absolutely. So I didn't even mention lifestyle, but there's clearly so that the body organs in the body talk to each other. And there's really only a couple of ways they can do that. They could talk to each other from the blood, or they could talk to each other from the nervous system. And there's an intimate connection between the nervous system, for example, and organ health related to the immune response. So lifestyle interventions, things like stress reduction, all of the lifestyle interventions we're talking about, exercise, all of these things will impact the immune system. And there are studies coming out, for example, of a link between exercise and how the heart can remodel, for example. Now, the link between those two, how it involves different immune cells, that's unclear. But it's pretty evident, and we see it all the time. One of the things I didn't mention about that patient that recovered, he also became a vegetarian and lost 80 pounds. Now, that probably had as much an impact as the drugs that we used. and who knows which had greater impact. But it's all connected. And there are clearly studies for atherosclerosis, for example, that along with the dietary modification, that there are many lifestyle interventions, sleep health, exercise, stress reduction, all of these things will impact the disease, and they usually impact inflammatory response at the same time. Yeah.
I'm just curious about the genetic component, because so many of us have heard from family members, oh yes, you know, heart disease at a certain age, very common. And the chicken and the egg question with the immune system and heart disease, I'm curious if there's genetic studies going on to sort of create some numbers around that.
Yeah, no, so that's a very good question, and I think, so it depends on what kind of genetic disease we're looking at. So if we look at the lens of, just say, heart failure, for example, we are now realizing that there are many, many more genetic mutations of proteins in the heart that can cause heart failure, for example. But a kind of a quandary that's always been the case is you're born with a genetic mutation, and yet some people will have that genetic mutation and have no heart failure. And others will have that mutation and have heart failure present early in life. And many others may have a mutation not present until their 5th, 6th decade with heart failure. So there's a lot of unknowns about why there's this, what we call incomplete penetrance in some people, and why disease decides to manifest in this period of time. We actually have looked at, again, in animal models, one of the things that causes a progression from subclinical to clinical kind of outcomes is the degree of inflammatory response within that heart, okay? And remember, the inflammatory response is simply a response to injury. So these mutations are causing low levels of injury in the cardiac myocytes generally, and it can develop an inflammatory response over time. But there are probably other things going on aside from that. So remember, the immune response is just one component. We have other drugs that target a whole host of other pathways that can slow progression of disease. But you're right, there is a genetic component. There's probably also links between genetic components of the immune response. And this happens, there's actually a specific example of that. There's a long name called CHIP, which is a change in your bone marrow hematopoietic stem cells. As we age, we have mutations in our bone marrow, and that predisposes to more heart disease as the highest predictor. It was actually looked at as a potential risk factor for leukemia. But what was found is, yes, there's an increased risk of leukemia with some of these mutations that affect the bone marrow, but it's actually much higher for heart disease. And that's probably an inflammatory link. Yes, sir.
We know that inflammation is involved in heart disease. We know that coronary artery disease starts probably much earlier than we think, maybe in the 20s and 30s. And we know that certain families have a high incidence of heart disease. Almost everybody in that family dies early because of coronary artery disease. It seems to me as we get more and more into being able to evaluate the genome of these people, we're going to be able to find more and more genes that are involved in causing this inflammation. We now know in colitis that there may be 37 to 40 different genes that are causing the inflammation in colitis. We didn't know this a few years ago.
Yep.
This is all new. It seems to me as we get further and further into this, we're going to be able to look into the genetic mutations that are there in each individual. And I think the future is that if we can identify these genes and use CRISPR to go in and remove these bad genes and put in a new gene, we're going to be able to stop this inflammation before it becomes serious. And I think this is in many diseases. I think this will be in colitis. This will be in Alzheimer's disease. And I think that may be the future to treating many types of our diseases as we're able to identify these new genes that are causing all this inflammation.
Yep. No, I mean, I don't think I could say it better. There's just an explosion of information now about the way genomics links to multiple diseases. Now, coronary disease, though, that's a vascular issue. And what we're talking about here is a myocardial issue. The two are linked, but the coronary disease, the atherosclerosis, is also linked to an inflammatory response. And there have been, over the last just few years, there have been multiple new genes that have been identified through something called genome-wide association studies and others that have shed new light on mechanisms for what's causing atherosclerosis. So you're absolutely right. The understanding the genome will really open up a new window in all of these diseases.
Hi. I am wondering, it's well known the immune response and been studied for decades around pulmonary disease. And I'm wondering about the association or lessons learned. Lung cells are different than heart cells. But I'm wondering from that cellular level, and also just thinking about the oxygen diffusion to the heart and the impact that inflammation is playing in that role. So where does lung disease come into an association with early heart disease, and what the implications might be on the inflammatory response?
Yeah. So the usual. There's multiple layers to that question. There could be diseases that are broad inflammatory diseases that can impact the heart and the lungs. Sarcoidosis is a good example of that. Okay, but there's also specific local inflammatory responses that'll occur in the lung because of heart failure as a secondary response. So one of the things that we see in heart failure is something called pulmonary hypertension, or very high pressures inside the lung. And while that is initially due to just kind of fluid changes, long term it's not the fluid, it's an actual remodeling of the lung. And this is related to just kind of mechanical load on the lungs causing injury and inflammation, just like we're seeing in the heart. So there is a link, and if you look in the lungs of animals, for example, with heart failure, you'll see a lot of inflammatory cell infiltration. But this is an injury response. So that's a little different than a global kind of auto-inflammatory response that affects the both. Yeah. Mm-hmm.
Thank you, Dr. Prabhu. And thank you, everyone, for your questions. Dr. Gupta, you have one more, and that is going to wrap up the Q&A for this evening, and we'll then go to Dr. Henderson.
So sorry to take extra time, but I want to go back to the slide that you had with 7 million. It's in terms of population today who are facing
the early slide?
Yeah, I think it's at a very early stage that So you look at 7 million people, you are putting the cost down at 70 billion. We are now basically shifting demographically into the nation where more and more people are going to be falling in the category of higher age individuals. This 7 million number will keep on increasing rather than otherwise. And these projected total costs are based on the current therapies that we know. But as we look into the advanced therapies, the costs are going to then skyrocket. Are there certain ways that the medical profession, especially in the primary care, currently the serum biomarkers are looking for cardiac diseases. They focus more on rather than inflammation. That if one can start looking and putting more of the preventative pieces to manage the inflammation much early on, along with the comorbidity, to pull down these numbers, but also associated economic burden, because you just start looking at these numbers and you say, how will we bear this economic burden?
Yeah, no, first of all, if we could prevent disease, that would be the way to go. I mean, there's no question, right? The impact of prevention is far beyond treating advanced disease, I think, from a societal level. The issue is that prevention sometimes is hard, and we see it all the time. What are we going to do when patients have disease? So the cost analysis, we can look at it two ways. New therapies are costly, but if you can reduce hospitalizations with new therapies, there's an offset of those costs of those hospitalizations. So I don't have to tell you, a cost analysis would need to be done as to what is the benefit versus the burden, so to speak. My sense is that you get patients feeling better, the cost landscape, the cost perspective changes completely. But it's an important societal issue. And these aren't my numbers. These are the AHA numbers for 70 billion. It might be well different than that, depending on what these new treatments are. For example, everybody's heard of CAR T cells used for cancer. Well, there are studies now that you can use CAR T cells to target heart fibrosis. And there is a company now trying to develop CAR T cells for the treatment of heart failure. So all these things are quite expensive, right, in the cancer world. And the question is, how effective will they be? Can we offset the cost of repeated hospitalizations, which is the main cost driver in heart failure? Thank you.
Thank Dr. Prabhu for sharing the lessons learned from his research with us. As he mentioned, I think many of us, if not most of us in this room, including myself, have family members who've been affected by heart disease. So we are especially grateful for the work you're doing to advance our understanding of heart disease and thereby enhance treatment options for future generations. I also want to thank our donors who make cutting-edge research like this possible. So a huge shout out and thank you to all of you. If you would like to share some of the lessons learned tonight with your friends and family, or if you want to revisit parts of this talk, we did video this presentation tonight, and this will be up on all of the Foundation's media sites, our Facebook and Instagram and webpage and so forth. So you will be able to revisit this presentation if you want to. I want to thank you all for joining us this evening. For those who are in person, if you would like to stay, I'm sure Dr. Prabhu would be willing to answer some more questions if we didn't get a chance to entertain your question during the talk. So thank you all, and thank you again to our speaker.